Hi, I'm Ziad Ali from St. Francis Hospital in New York. I'm the director of the De Matteis Cardiovascular Institute at St. Francis Hospital, and I'm the director of the Angiographic Core Lab at Cardiovascular Research Foundation. So I had the pleasure of giving the keynote lecture, as you know, and it was really based on determining the future of intracoronary physiology, intracoronary imaging, whether we need both, one, or none. And it was an interesting topic to be described because it allowed me to go and review all of the literature and really be critical. One of the ways I started this off was to say, let's look at the bigger picture from the stakeholders, which are from the patient's point of view, from the lesion's point of view, and from the physician's point of view. And can intracoronary imaging or physiology help the patient, help the lesion, or help the clinical outcome, which in this case would be death, heart attack, or repeat revascularization. And really what we did is dissect out really carefully all of the clinical data presented, and I asked the question, are we just seeing and believing what's at face value? Or are we really diving down into the mechanism by which some of these benefits exist? And essentially what I summarized this to be was that while intracoronary physiology is extremely important, so far the data in totality suggests that it can prevent really peri-procedural myocardial infarction. And the way that it does that is by reducing the total amount of stents that you need. As soon as you become more aggressive, and that difference in stents between other groups disappears, then the clinical benefit in reduction in peri-procedural myocardial infarction disappears. Then I described that the benefit of imaging is really based on the ability to see plaque, and it doesn't really matter whether that's invasive imaging or non-invasive imaging. For example, from CT scanning, when we're able to see high-risk features in the plaque, we know those patients have an event. When we're able to see high-risk features intravascularly by using OCT or IVUS, those patients actually predict events. And then I finished off by saying, why can't we have both? Because we know that physiology can be helpful in certain circumstances. We know that imaging can be helpful in both, another set of circumstances. We have the technology. Why can't we merge them to be much more user-friendly and directly applicable to patients? One of the studies that actually was just published was the FLAVOUR study published in the New England Journal, which showed that whether you use a physiology-guided approach in intermediate lesions or an intravascular imaging approach, the clinical outcomes at 2 years were the same. What they found was that if you did intravascular imaging, you tended to put more stents in, longer stents, and that had a cost implication because you were doing more activity up front. But there really wasn't an increase in peri-procedural or other myocardial infarction, so there wasn't a cost, at least early on, of putting that extra additional stent length in. Our hypothesis is that by capping the lipid or putting a cover on top of the lipidic plaque, which is what ultimately leads to heart attacks, we can potentially prevent those heart attacks in the future. And one of the nice things about the intravascular imaging data is that we have now 5-year data, and maybe even longer, to show that if you cap these plaques, you may be able to prevent these heart attacks. What we learned from the earlier data is that really when you do a medically managed patient, that patient doesn't start to have heart attacks until 3 or 4 years later. And so we need to think much more long-term than what we've been doing at the moment. We're very excited to present the Illumian 4 randomized control trial data later this year. I was the global PI along with Ulf Landmesser and the chairman Greg Stone. This is a 2,500 patient randomized control trial comparing OCT-guided PCI to angiography-guided PCI with clinical outcomes. So that's an exciting study to present, which could shift practice in one way or another, but we're excited to be able to present that data soon.